So let's continue spinal cord injury. Now discussing the common complications of it. So we have urgent medical conditions and clinical complications. So under urgent medical conditions, we have the autonomic dysreflexia, deep vein thrombosis, pulmonary embolism, and pneumonia. So individuals with spinal cord injury are at risk for various urgent medical conditions due to the complex interplay of immobility, autonomic dysfunction, and respiratory compromise. These conditions can be life threatening and require prompt recognition and management. With autonomic dysreflexia, this is a potentially life threatening condition that can occur in patients with spinal cord injury at or above the T6 level. It results from an exaggerated autonomic response to a nauseous stimulus below the level of the injury, leading to a rapid and severe increase in the blood pressure. So, what triggers this includes bladder distension, like a blocked catheter or urinary retention, if there's bowel impaction, or skin irritation, like pressure ulcers or tight clothing below the level of the lesion, or other forms of discomfort below the injury level. The symptoms are sudden and severe hypertension, which is really a significant rise in blood pressure. So this is really noticeable. There's pounding headache, sweating above the level of injury. There's flushed skin, and you can see it in the color of the face. Yeah, particularly in the face and the neck. Nasal congestion, blurred vision, and anxiety. There's also a bradycardia, or the slow heart rate. So how do we manage this? We need to have an immediate action. We need to sit the patient upright to lower the blood pressure and look for any tight clothing. So we need to loosen that up. And we need to identify and remove the trigger. So if it's the tight clothing, we need to loosen that up. We also need to check the urinary catheter. So if this is above T6, if this is T6 level, so a lot of them would be urinary, all of them would be urinary incontinent, right? So we need to check the urinary catheter for obstruction. They are also bowel incontinent. So assess the bowel impaction. They might have not moved yet. So inspect for any sources of skin irritation. Since their T6 level, they don't have enough mobility, T6 and below, whether it's complete or incomplete. So they sometimes needed to be assisted for mobility. So they're at risk for pressure ulcer. So if the blood pressure does not normalize quickly, we need to administer anti-hypertensive medications under medical supervision. But in acute setting, you just tell the nurses and they will provide the blood pressure medication. We need to also do a routine bladder and bowel management, pressure relief strategies, and skincare, which are critical to minimizing triggers for autonomic dysreflexia. So with deep vein thrombosis, so this is a blood clot that forms in the deep veins, usually in the legs. Spinal cord injury patients are at high risk of DVT due to prolonged immobility, which slows the blood flow and reduce the muscle contractions in the legs, which normally help to circulate the blood. So the swellings that you will look for are the symptoms that you will look for are swelling, warmth of the skin, redness or pain in one leg, often in the calf or thigh. However, DVT may be asymptomatic. So they might not have these symptoms, especially in spinal cord injury patients who may have reduced or absent sensation in the affected limb. So they might not tell you, I have pain in my leg. So you just really need to do an accurate check for that one. So how do we manage this? So ultrasound imaging is commonly used to confirm a DVT diagnosis. That's why if there is a suspicion of a DVT, we actually make a recommendation to have ultrasound to confirm this. We also provide anticoagulant medications once DVT is recognized to be present, such as heparin or warfarin. They are typically administered to prevent clot growth and reduce the risk of clot migration, or for it to become an embolus. So how do we prevent DVT? We need to have a regular use of compression stockings for these patients. We could also provide pneumatic compression devices that you usually see in inpatient, and anticoagulant medications that are prescribed for the patients. So these are common preventive measures. As physical therapists, we have to provide range of motion exercises and early mobilization. We need to encourage this as much as possible. If untreated, a DVT can dislodge and travel to the lungs, leading to a pulmonary embolism, which is really, we know that is potentially fatal complication. So what is pulmonary embolism? So this occurs when there's a blood clot, and typically originating in the deep veins of the legs. It travels to the lungs and obstructs blood flow in the pulmonary arteries. So pulmonary embolism is a life-threatening condition, and it's a major risk for patients with spinal cord injury, especially if they have already developed a DVT. So, what are the symptoms for this pulmonary embolism? A patient will have sudden shortness of breath. They will feel sharp chest pain, often worsening with deep breathing. There's rapid heart rate and low blood pressure. They cough, they are coughing, which may produce blood tinged sputum. There's dizziness, fainting, or a feeling of impending doom. So, we have to manage this pulmonary embolism. This is a medical emergency that requires urgent hospitalization. So treatment typically includes, again, just like DVT, anticoagulants to prevent further clotting, and thrombolytic agents, the busters in severe cases. Oxygen therapy has to be provided when there's shortness of breath. In some cases, mechanical ventilation may be necessary for respiratory support once it impedes already the pulmonary blood flow. In severe cases, surgical procedures such as an embolectomy or clot removal or insertion of an inferior vena cava filter to prevent clots from reaching the lungs may be considered. And I've seen this many times with patient post-op. They put in an IVC by the groin area. So preventive measures are similar to those for DVT, including anticoagulants, compression devices, and early mobilization. So pneumonia, about with pneumonia? Pneumonia is a lung infection that can result from bacteria or viruses or other pathogens. Spinal cord injury patients are at elevated risk for pneumonia due to impaired respiratory muscle function, particularly if the injury is at or above the T6 level. Just like seen in autonomic dysreflexia. Weakness in the diaphragm and intercostal muscles can lead to ineffective cough, poor clearance of secretions, and decreased lung capacity. So, we recognize pneumonia with symptoms as fever, chills, and sweating. There's also productive cough with yellow, green, or blood tinged mucus. There's shortness of breath and chest pain as well. Fatigue and weakness is also seen. So there's a lot of symptoms that are similar to pulmonary embolism. So, how do we manage these patients? First, we need to diagnose whether there is pneumonia, and is typically diagnosed through chest x rays, blood tests, and sputum cultures. Antibiotics are prescribed for bacterial pneumonia, while antiviral medications may be used for viral infections. We provide supportive care, including oxygen therapy and hydration, and these are all essential. For patients with severe respiratory compromise, there's a non invasive ventilation. A BiPAP or invasive mechanical ventilation may be necessary. Regular respiratory exercises such as incentives, spirometry, and deep breathing help improve lung function, and this is preventative measures. We need to provide assistive cough techniques, and suctioning can also aid in clearing secretions, and usually done by your respiratory therapist. So we have provided vaccinations such as the pneumococcal and flu vaccines, which are recommended to reduce the risk of respiratory infections. We provide frequent repositioning and maintaining an upright posture when possible, to help prevent fluid buildup in the lungs. So, as a summary, SCI patients, caregivers, and healthcare providers must be trained to recognize early signs of these urgent conditions, as some symptoms, such as pain, may be absent or altered due to sensory deficits. Preventive strategies such as regular respiratory exercises, anticoagulant therapy, and skin and bladder management are essential to reducing the risk of this condition. Conditions like your autonomic dysreflexia, DVT, pulmonary embolism, and pneumonia require rapid intervention to prevent severe complications or death. Patients and caregivers should be educated on emergency protocols and when to seek immediate medical attention. So, patients with SCI should undergo routine health checks and screenings to detect any early signs of complications. This may include regular lung function tests, blood pressure monitoring, and ultrasound checks for DVT if risk factors are present. Preventing and managing these urgent conditions requires a multidisciplinary approach involving primary care providers, physical and occupational therapists, respiratory therapists, and specialists such as pulmonologists or hematologists. So, by staying vigilant and adopting preventive measures, patients with SCI can reduce their risk of these serious complications and ultimately improving their quality of life and long term outcomes. So, now let's go to your clinical complications of SCI. Patients are at risk for a range of clinical complications due to changes in muscle tone, bone density, circulation, and joint mechanics. So, understanding this complication is essential for effective management and prevention, as they can significantly impact the patient's mobility, independence, and quality of life. So let's look at some overview of some common clinical complications associated with SCI, including your postural hypotension, spasticity, shoulder pathology, heterotopic ossification, and osteoporosis. So for postural hypotension or orthostatic hypotension, this is a sudden drop in blood pressure that occurs when moving from a lying to an upright position, commonly seen in individuals with a CI, particularly in those with injuries at or above the T6 level. So it results from impaired autonomic control and reduced venous return due to prolonged immobility and muscle atrophy. The symptoms are dizziness, lightheadedness, and blurred vision. There's also nausea, fainting or feeling faint. So We manage this with gradual position changes when transitioning from lying to sitting or standing. Patients should make these changes slowly, allowing time for the blood pressure to stabilize. We manage this also with compression garments. So we provide abdominal binders and compression stockings to help improve venous return and stabilize the blood pressure. We provide tilt tables and reclining wheelchairs. So tilt tables allow patients to practice standing with support. We do it, slowly, while reclining wheelchairs enable gradual upright positioning as well. So we could also provide medication. So in some cases, medications such as fludrocortisone or midodrine may be prescribed to help regulate blood pressure. So we could prevent this by regular sitting and standing exercises where possible, help improve circulation and reduce the severity of orthostatic hypotension over time. Another complication is your spasticity. So spasticity is a common complication in SCI, particularly in those with injuries above the T12 level. It is characterized by increased muscle tone, involuntary muscle contractions, and exaggerated reflexes due to the loss of normal inhibitory signals from the brain. So, symptoms of spasticity is muscle stiffness and tightness. There's sudden uncontrollable muscle spasms. There's pain or discomfort associated with spastic muscle movements. We manage this with stretching and range of motion exercises. There's regular stretching and ROM exercises to help reduce muscle tightness and improve flexibility. We manage it with medication, so muscle relaxants such as baclofen, tizanidine, or diazepam may be prescribed to manage spasticity. Baclofen pumps can deliver medication directly to the spinal cord for severe cases. So, botulinum toxin injections. Botox injections can be used to reduce spasticity in targeted muscles by temporarily blocking the nerve signals to the muscle. There can also be surgical interventions. So, in refractory cases, surgical procedures like selective dorsal rhizotomy, cutting the specific nerve roots, may be considered. So, reducing spasticity will improve the mobility. It eases caregiving tasks and reduces the risk of contractures and joint deformities. So, another complication is your shoulder pathology. This is a common complication in SCI patients, particularly those who rely on their upper body for mobility and transfers. The repetitive strain on the shoulders from wheelchair propulsion, transfers, and weight bearing activities can lead to overuse injuries such as rotator cuff tears, impingement syndrome, and even bursitis. Symptoms that you will see are shoulder pain and tenderness, especially during movement. There's decreased range of motion and strength in the shoulder. There's also swelling and inflammation around the joint. We manage this through strengthening and stretching exercises. So, strengthening the rotator cuff muscles and performing regular stretching exercises can improve shoulder stability and flexibility. So, activity modification, adjustments to the frequency, technique, and mechanics of transfers and wheelchair propulsion can reduce shoulder strain. We provide assistive equipment, so transfer aids like sliding boards and power wheelchairs can reduce the physical load on the shoulders. Physical therapy with focus on shoulder stabilization and postural exercises can help reduce pain and prevent further injury. We manage the pain through NSAIDs, corticosteroid injections, and other pain management techniques may be prescribed to relieve inflammation and pain. Strengthening and conditioning exercises should begin early in rehabilitation To reduce the risk of shoulder injuries, patients are encouraged to use proper techniques for transfers and other repetitive movements. Another complication is your heterotopic ossification. This is an abnormal formation of bone tissue in soft tissues such as your muscles and tendons. It's often around the hip, the knee, or even the elbow. So, heterotopic ossification is common in SCI patients and can lead to pain, restricted joint movement, and functional limitations. There's joint swelling, warmth and pain. There's decreased range of motion and stiffness in affected joints, palpable lumps or bony growths near the joint. So, heterotopic ossification is diagnosed using imaging techniques such as your x rays or bone scans. Blood tests showing elevated alkaline phosphatase levels can also indicate that there's heterotopic ossification. So, non-steroidal anti-inflammatory drugs and bisphosphonates may be prescribed to slow bone growth. We should provide gentle range of motion exercises to help maintain joint mobility without exacerbating the growth of heterotopic ossification. In severe cases where HO severely limits movement, surgical excision of the bony growths may be considered after the bone growth has stabilized. While the exact cause of HO is not fully understood, early mobilization, regular range of motion exercises, and maintaining optimal joint positioning may help reduce the risk of developing HO. Lastly, for our clinical complications, we have osteoporosis. This is a condition characterized by decreased bone density and increased risk of fractures. SCI patients are at high risk for osteoporosis due to reduced or absent weight-bearing activity, which leads to bone demineralization, particularly in the lower limbs. So, osteoporosis often has no noticeable symptoms until a fracture already has occurred. In SCI patients, fractures may happen with minimal trauma or even during routine care. Signs of a fracture can include localized pain, swelling, or deformity, although these may be hard to detect due to sensory deficits. Weight-bearing activities has to be provided as a mean of management, like standing frames, tilt tables, or body weight support devices, can provide intermittent weight bearing stimuli which may help maintain bone density. For medication, bisphosphonates or other medications that reduce bone loss may be also prescribed. Calcium and vitamin D supplements, adequate calcium and vitamin D intake supports bone health. We can provide exercises that involve muscle contractions even without full weight bearing. It can still stimulate the bone growth and improve bone density. So, early weight bearing activities were feasible, and proper nutrition are key to reducing bone density loss. Regular bone density scans help monitor bone health and detect osteoporosis early. So, a key consideration for managing clinical complications in SCI would have to be regular monitoring, interdisciplinary approach, patient and family education, and individualized care plans. These complications can be significant barriers to independence and quality of life for individuals with SCI. So, proactive management, preventive care, and regular monitoring play a critical role in mitigating the impact of these complications, helping patients achieve the best possible outcomes and maintain a high level of function and well being. We're going to dig deeper onto autonomic dysreflexia. This is a serious and potentially life threatening condition that can affect individuals with spinal cord injury or at or above the T6 level. It occurs when a nauseous stimulus below the level of injury triggers an exaggerated autonomic response, resulting in a rapid and dangerous increase in blood pressure. The bladder is a common source of stimuli that can cause autonomic dysreflexia or AD, especially because SCI patients often have compromised bladder function and rely on catheterization or other interventions to manage urinary output. So here are key bladder related causes of autonomic dysreflexia. So SCI patients frequently use indwelling catheters or perform intermittent catheterization to manage bladder emptying. If a catheter becomes blocked, kinked, or malpositioned, urine may accumulate in the bladder and it will lead to overdistension. So the excessive stretching of the bladder wall will send strong signals through the autonomic nervous system, but excuse me, but due to the injury, these signals cannot reach the brain. Instead, they trigger a reflex response in the spinal cord below the injury level, resulting in uncontrolled vasoconstriction and a spike in blood pressure. So, what are the signs and symptoms of bladder distension? There's severe sudden onset of headache, sweating and flushing above the level of injury, high blood pressure and bradycardia, anxiety, or even feeling of unease. So we manage this with immediate action. We check the catheter for any signs of blockage or kinking. So we straighten or reposition it if needed. So if the catheter is blocked, it may need to be irrigated to remove the blockage or replaced entirely. So we could tell our nurses to do this. Regular catheter maintenance, frequent monitoring, and ensuring proper catheter positioning reduce the risk of blockage or kinking. Urinary tract infection. SCI patients are at high risk for urinary tract infections due to the frequent need for catheterization and changes in bladder function. Bacterial growth in the bladder or urethra can lead to inflammation, which can trigger autonomic dysreflexia. So, the infection and inflammation caused by a UTI can irritate the bladder wall and surrounding tissues, sending strong autonomic signals through the spinal cord. So in SCI patients, this autonomic response is not regulated properly, resulting in a reflexive increase in blood pressure. So usual symptoms of AD is headache, flushing, and sweating. These are signs and symptoms of AD that are triggered by UTI. So, the signs of infections are cloudy, foul smelling, or discolored urine, increased spasticity or pain in the lower abdomen. There's fever or chills, though fever may not always be present in SCI patients. I can also add in here sometimes the patients can be confused. So we manage this with really immediate actions. If UTI is suspected, let's consult a healthcare provider for diagnostic testing like urinalysis and urine culture. UTIs are also typically treated with antibiotics tailored to the causative bacteria. Patients may also receive guidance on catheter hygiene to reduce future risk. So, maintaining clean techniques for catheterization, adequate hydration, and regular bladder emptying are key preventive strategies. So, there's also sometimes bladder stones. So, bladder stones can form when urine sits in the bladder for prolonged periods, leading to the precipitation of minerals. This condition is more common in SCI patients due to impaired bladder emptying and frequent catheterization. So, we need to have regular monitoring and preventive care. We have to educate patients and caregivers regarding these bladder causes of AD. We have to have a prompt response and close communication with healthcare providers. Okay, so another cause is bowel. Okay, so individuals with SCI often experience neurogenic bowel dysfunction, which can lead to reduced bowel motility and chronic constipation. So constipation causes the accumulation of stool in the colon and rectum, leading to distension and increased pressure in the bowel. So we manage this by assessing for fullness, and steps to relieve constipation should be taken if appropriate, like laxatives, stool softeners, or enemas may be used to facilitate bowel movements. So patients are typically placed on a structured bowel regimen to prevent constipation. Hemorrhoids. These are swollen blood vessels in the rectal area, often resulting from chronic straining during bowel movements due to constipation also. So hemorrhoids can become inflamed or thrombosed, meaning clotted, leading to pain, itching, and bleeding. So there's also anal fissures. So anal fissure is a small tear in the lining of the anal canal, often caused by passing hard stools or straining bowel during bowel movements. Anal fissures are painful and can lead to bleeding, especially during bowel movements. So if we see this, we need to treat this by topical ointments, stool softeners, or sitz baths. In chronic cases, surgical intervention may be necessary to also promote healing. So, other um, other causes would be such as scrotal compression, right? Sorry. So let's go first to the skin causes. So, like pressure ulcers, they are known as bed sores. It occurs when prolonged pressure on the skin restricts the blood flow, leading to tissue damage. So, SCI patients are at high risk for pressure ulcers due to immobility, reduced sensation, and reliance on wheelchairs. So, we manage this with relieving pressure by repositioning the patient or using a pressure relieving device such as your specialized cushion or mattresses for bed or for your wheelchair. So regular wound care, including cleaning, dressing changes, and assessment by healthcare providers, is essential to prevent infection and promote healing. So if there is tight clothing or constrictive items, what we need to do is remove or loosen the constrictive item, unfasten tight belts, remove tight shoes, or adjust the socks. So wearing loose fitting clothing and avoiding tight or constrictive items can help prevent skin irritation and autonomic dysreflexia episodes. So if there is also ingrown toenails, it occurs when the edge of a toenail grows into the surrounding skin, and it causes inflammation, pain, and sometimes infection. So ingrown toenails are particularly common in individuals with limited foot care routines or improper footwear. So we need to do regular foot care, including proper toenail trimming and wearing appropriately fitting shoes. That will reduce the risk of ingrown toenails. So SCI patients should regularly check their feet or have caregivers inspect them. Other skin causes are blisters. So blisters are fluid-filled sacs that form on the skin due to friction, burns, or other types of skin irritation. So they commonly occur in areas exposed to repeated friction, such as from wheelchair, shoes, or prosthetics. So we need to remove the source of irritation and adjust or remove the shoes, braces, or other equipment that will cause the frictions. So let's go to other causes like scrotal compression. So this compression or injury to the scrotum, such as from prolonged sitting, tight clothing, or accidental trauma, can be a trigger for AD in male SCI patients. Due to a sensory loss, they may not perceive pain or discomfort in this area, making them more vulnerable to unnoticed scrotal irritation or compression. How about sexual stimulation? So, sexual activity, including physical stimulation of the genital area, orgasm, and ejaculation, can act as a nauseous stimulus in SCI patients, particularly those with injuries above the T6 level. So, the intensity of stimulation and physiological changes during sexual activity can also trigger autonomic dysreflexia. Even labor and childbirth can be a cause. They are intense physical processes involving uterine contractions, there's cervical dilation, and the eventual delivery of the baby. So each of these processes generates strong nociceptive signals, which can trigger AD in SCI patients. Even menstruation for females. So the menstrual cycle, particularly menstruation, involves uterine cramping, hormonal fluctuations, and tissue breakdown, which can act as a nauseous stimulus in SCI patients, triggering autonomic dysreflexia. So the discomfort and uterine contractions associated with menstruations are the primary triggers for this. So even any condition that cause abdominal pain like appendicitis, gallstones, gastroenteritis can also cause AD. So I want you to be able to read this. How do you get autonomic dysreflexia? Again, first there should be you will find an irritation below the level of SCI, such as a full bladder, that will send signal up to the spine, which will cause constriction of blood vessel, and this will cause high blood pressure. So it will send signal to the brain. There will be slow pulse and dilatation of blood vessels above the injury as an attempt to compensate for the rise in blood pressure, causing symptoms. The attempted compensation message cannot pass through the spinal cord, and blood pressure will continue to rise. So, what are the signs and symptoms? Again, there's that blood pressure that is above 20 to 30 millimeter mercury rise. There's sweating, pounding headache, flushed appearance. There's tight chest and stuffy nose, and even blurred vision. So this is an emergency. This is an emergency condition that needed an immediate response from all of us as physical therapists. So, as a conclusion, it is essential for you, family members, or caregivers to recognize and understand the potential causes, prevention, and treatment of AD. So, if an episode of AD is identified quickly and treated immediately, the symptoms may then subside, thus removing the likelihood of complications.